Hello, everyone. My name is Joseph Muller, and my presentation is on HIV/AIDS in New York. Before we get started, here's just a brief overview of what is going to be covered in this presentation. We will start off with a background of New York and a neighboring state, Pennsylvania, for comparison. Then we will move to a small background of the HIV/AIDS outbreak in the United States. From here, we will look at the epidemiology of HIV/AIDS in the state of New York, some of the implemented preventive measures and barriers. And to wrap up the presentation, we will finish with a prevention strategy. New York is one of the most developed and populous geographic regions in the United States. It covers approximately 55,000 square miles and has a population of over 20 million. This equates to approximately 430 individuals per square mile. Of this population, about 54% are non-Hispanic white, followed by 19.5% Hispanic or Latino, 17.6% Black or African American, 9.3% Asian, 2.8% two or more races, 1% American Indian or Alaska Native, and 0.1% Native Hawaiian or Pacific Islander. The main socioeconomic indicators in the state of New York is poverty. Approximately 14% of the population, which is roughly 3 million individuals, are considered to live in poverty. The second most prevalent indicator is education. 87.4% of the state population was noted to be a high school graduate or higher, and 38.1% were noted to have a bachelor's degree or higher. PrEP use among individuals totaled approximately 39,000, with the majority of users falling between ages 25 and 34. Pennsylvania, a neighboring state to New York, covers approximately 45,000 square miles and has a population of just over 13 million, which is approximately 291 individuals per square mile, which is just over half of that of New York. The dominant race is also non-Hispanic whites at approximately 74%, followed by 12.2% Black or African American, 8.4% Hispanic or Latino, 3.9% Asian, 2.3% two or more races, 0.4% American Indian or Alaskan Native, and 0.1% Native Hawaiian or Pacific Islander. Poverty in Pennsylvania is about the same as New York at 12%. However, there are higher rates of high school education and bachelor's degrees or higher at 91.4% and 33.1% respectively. And just as a comparison, PrEP use in New York was approximately 3 times that of Pennsylvania. In Pennsylvania, the highest age group of people with HIV were among those 55 and older. As of 2020, there were approximately 36,000 people with HIV, with an incidence rate of 7 per 100,000 and mortality of 6.3 per 100,000. The incidence rate is slightly higher than the mortality rate, which is close to stabilization. However, it has not quite reached it yet. The highest number of cases of HIV by race or ethnicity was seen among Black or African Americans. When observing the numbers of cases by sex, males were seen to have the majority of cases, which was approximately 72%. The highest mode of transmission of HIV in the state was among men who have sex with men at approximately 57.9%. However, for females, the highest mode of transmission was among those engaging in heterosexual contact at 72.2%. The outbreak of what would become to be known as HIV/AIDS was first recognized June 5th, 1981, due to outbreaks of pneumocystis pneumonia in Los Angeles, California. And on the same day, 20 individuals were reported to have Kaposi sarcoma in New York City, New York, which were both reported to the CDC. By the end of 1981, approximately 42,000 individuals were living with HIV, and roughly 20,000 new cases of HIV were nationwide. The data gathered for this study for New York was obtained from the CDC Atlas Plus database. Data from 1981 to 2007 was not able to be obtained without a data request, which was not performed for this study. All of the graphs were generated using SAS on demand for academics, and the data available from the CDC Atlas Plus database. Figure 1 on the left shows the incident cases of HIV for the whole New York population per 100,000 population from 2010 to 2021. This figure shows a decline in the number of incident HIV cases from 3,300 in 2010 to 1,700 cases in 2021, a decline of approximately 1,600 cases. Figure 2 on the right depicts the decline in incidence rate for the whole New York population from over 20 per 100,000 population in 2010 to just over 10 per 100,000 population by 2021. Figures 3 and 4 depict the rise in prevalent cases and the rise in prevalence rate per 100,000 population for the whole New York population from 2010 to 2021, respectively. The prevalent cases rose from approximately 115,000 cases in 2010 to over 124,000 cases by 2021, whereas prevalence rate rose from approximately 700 per 100,000 to over 730 per 100,000 by 2021. Figures 5 and 6 depict HIV mortality cases and HIV mortality rate for the whole state of New York from 2010 to 2021. As of 2010, there were approximately 2,200 deaths related to HIV, with a mortality rate of approximately 13.5 per 100,000, which had shown an overall decline to approximately 1,700 deaths, which was an HIV mortality rate of about 10 per 100,000 by 2018. After 2018, there was a spike in HIV mortality cases to over 2,400 in 2020, which was a mortality rate of 14.5 per 100,000. And this fell to just over 2,200 cases, which was approximately 13 per 100,000 by 2021. And due to the time constraints, I thought that figures 1 through 6 were the most important because they were the overall state rates. Shortly after the outbreak of HIV in 1981, HIV prevention strategies began to appear the following year. These were mostly initiated by homosexual males in California and New York, where the first cases were observed. Many of these groups were grassroots initiatives formed on the basis of raising awareness for HIV and AIDS, providing education, and offering strategies to reduce the risk of acquiring or transmitting HIV. One of the first CDC initiatives was the National AIDS Information Line. It was a hotline where individuals could call with questions regarding HIV. Around 1985, the CDC rolled out HIV antibody testing, implementing HIV education programs in high schools and colleges, and surveillance systems in order to determine trends and risk factors related to HIV. The surveillance system seen during this time, as well as currently, are passive surveillance systems. From this point forward, many of the prevention strategies were implemented on a national scale due to the increases of cases. Some of the barriers mentioned from literature include a lack of motivation to change current behaviors, increases in injection drug use, rises in other sexually transmitted infections, having a declining belief of the severity of HIV, and high costs for HIV self-test kits. All of these barriers are then mentioned within the literature to be compounded by socio-demographic factors such as poverty, homelessness, and racism. To provide an example, Geiger and colleagues, as well as Johnson and colleagues, both conducted studies related to HIV self-test kits in the state of New York. Both of these studies found the self-test kits to be effective. However, the main barrier in both of these studies was related to the cost of the test kits. For these studies, the test kits were provided free of charge to the study populations. However, they were told what the cost would be had they purchased the kits outright. In both studies, the exact price of these kits were not disclosed. In order to achieve outbreak control, the state of New York and New York City have implemented the Ending the Epidemic Strategies to End HIV in NYC program. The overall goal of this initiative is to reduce the number of HIV infections to less than 750 new cases, which would put the state below epidemic levels. This initiative follows 5 key strategies to reduce the incidence of HIV through increasing the number of individuals receiving testing, increasing access to prevention methods such as condoms, PrEP, and PEP, optimization of medication adherence for those infected with HIV, identification and intervention for at-risk populations, and to implement more community-based interventions to reduce racism and the stigma of HIV. Thus far, the previously mentioned intervention strategies have been effective in attempting to end the HIV/AIDS epidemic in New York, which was observed in figures 1 through 6 on the previous slides. To further reduce the number of HIV cases, treatment prevention and PrEP used should be expanded and further studied. PrEP is a relatively new method of HIV prevention and may be quite costly for individuals who do not have medical insurance. Education on treatment as prevention and PrEP use should be expanded as a prevention method. This should be covered as part of the sexual education offered in high schools as well as colleges. In addition to this, facilities that offer counseling and HIV/AIDS education should have medical providers they work with to offer PrEP at no cost for individuals that are uninsured and are unable to pay for the medication out of pocket. This could be achieved through federal funding or funding provided by local, state, or government health agencies. Furthermore, HIV self-test kits should also be available for purchase at low cost for individuals that may not want to seek medical attention for testing. This would provide an option for those that are stigmatized or for individuals that do not want to disclose their HIV status. However, this may affect HIV surveillance data. In accomplishing these tasks, reduction in the number of HIV cases could potentially be reduced below epidemic levels and eventually ended. Here are my references. Thank you.